Well, good evening and welcome to this dramatic opening to the first of this summer's lecture series sponsored by Cornell's School of Continuing Education. Let me just add my thanks to those of Shelley, for those of you who I'm sure took shelter when you were asked to take shelter and then emerged to this beautiful, relatively sunny summer evening. Our theme for this year's lecture series is global health, by which we mean health in the broadest sense. The health of individual human beings over our life course, the health of human populations in what is all too clearly a fast-changing world with many new challenges presenting themselves to us, and the health of non-human populations that human beings depend upon and with whom we share the planet. Among all the great universities of the world, Cornell University, I think, may be uniquely positioned to address all of these aspects of global health. Cornell Weill Medicine, both in New York City and in Qatar, conducts leading-edge research in human health at every scale, from fundamental laboratory science to large-scale clinical studies. Here in Ithaca, the College of Human Ecology and the College of Agricultural and Life Sciences together are home to one of the nation's leading departments of nutritional sciences, approaching human nutrition through multiple disciplines and at multiple scales, from molecular biology to international food policy. Our College of Veterinary Medicine is home to the Department of Public and Environmental Health and recently received an historic gift from Cornell alumna Lisa Yang to endow the K. Lisa Yang Center for Wildlife Health, which addresses key challenges at the intersection of wildlife health, domestic animal health, and human health. And because we are one Cornell, researchers in all of Cornell's colleges at all of Cornell's campuses collaborate deeply with one another across disciplinary boundaries. In the spirit of One Cornell, then, it's my pleasure tonight to introduce Professor Shahrad Taheri, who is Professor of Medicine, Professor of Integrative Medicine, Assistant Dean for Clinical Investigations, and Director of the Clinical Research Corps at Cornell Weill Medicine in Qatar. Professor Taheri also holds an appointment as Honorary Professor of Medicine at University College London. Professor Taheri's distinguished career has combined health research, practice, and education. He is the author of more than 300 articles on subjects including endocrinology and metabolism, sleep and breathing, obesity and diet, and women's representation in clinical research in Qatar, as well as this topic for tonight, type 2 diabetes. In addition to his published research, Professor Taheri has long been active in driving national strategies and large-scale clinical research and interventions to address obesity and diabetes, first in Great Britain, now in Qatar. Most recently, I learned from Dr. Taheri at dinner tonight in West Virginia in the United States, where he came to consult with the state on what they can do to improve the situation there in their own state. With all of those travels, this is Professor Taheri's very first visit to our Ithaca campus. So please join me then in giving him a warm welcome to his talk tonight. Professor Taheri.
Well, thank you for that wonderful introduction, and I want to thank the organizer for inviting me to speak with you today. I'm going to start with some good news, then talk about some bad news, and some better news afterwards. So the good news is most of the people who come to my talk are the most smart people in the world. So that's the good news. Now we go to the bad news. So in terms of diabetes and type 2 diabetes, which we're talking about, you can see diabetes is one of the non-communicable diseases. And these non-communicable diseases, cardiovascular disease, cancer, diabetes, and respiratory disease, account for about 41 million deaths per year. And 71% of all deaths. And diabetes is a particular problem here, just showing globally. If you look at the picture, you will see the purple areas are the areas where they have high prevalence of diabetes, and you see the dark blue, which is the United States. It's got 34 million people affected with type 2 diabetes, and that's going to cost about $327 billion a year. So the medical management costs about $12,000 per year, and about $5,000 a year is out-of-pocket costs. So it's a very expensive disease, and it's growing in number every year. Of course, diabetes is the commonest cause of blindness, commonest cause of renal failure. People end up on dialysis requiring renal transplantation, commonest cause of amputations, very common cause of cardiovascular disease, increased risk of multiple cancers. Some of the most common cancers are associated with obesity and diabetes, which go hand in hand. Of course, it's also a driver of dementia. And unfortunately, type 2 diabetes is occurring at a younger and younger age. So the younger the disease occurs, the more likely people are going to be exposed to high blood sugars and abnormalities of type 2 diabetes that results in complications down the line. So it's expensive for the individual, the health services, and also the insurance companies who have to pay eventually to cover this care. So which disease would you not want? If you had a choice, is it going to be breast cancer, lymphoma, or type 2 diabetes? So let's look at 10-year survival of these diseases. So in breast cancer, because of advancements in medical care, it's 80% survival over 10 years. For lymphoma, it's 60%. But for diabetes, it's 50%. And not many people realize how bad type 2 diabetes is, and that affects survival. So diabetes is bad news. And I've explained why, because of all the complications. But what do we do? What options do we have available for people with diabetes? So we have diabetes education, and we have medical management, and also weight loss programs because of the association between diabetes and obesity. But I'm going to talk about something new. And what we're interested in terms of medical management is managing the blood sugars. We measure something called hemoglobin A1C. Your hemoglobin carries oxygen, the protein that carries oxygen, and it has sugar attached to it. And we measure HbA1c, which is a measure of blood sugar control over the previous 3 months. And the medical concentration is how do we get this HbA1c to be 7% or less to avoid complications such as blindness, kidney disease, and amputations, but also reduce blood pressure and also the lipid abnormalities, the high cholesterol abnormalities that we see in diabetes. So education is how do you cope with your disease? And medical management, how do we treat that disease? What can we think about it differently? So that's what I'm going to talk about. So what about diabetes education? Does it really make a difference? So this is a very busy slide, but this is a trial we did across Leicester and Birmingham in the UK. And what we did with randomized GP practices, primary care practices, into ones providing education for diabetes. And this was a really well-established education, and one that was providing usual care. So you can see in terms of individuals, there were 367 individuals who were randomized, and there were 31 primary care practices that were randomized. And we looked at HbA1c differences between the ones who received education and who didn't receive education. And again, another busy slide. You can see the difference in HbA1c here, minus 0.18, minus 0.205, but none of them are statistically significant. So if we look at p-value of less than 0.05 as being significant, but diabetes education actually made no difference. So diabetes education makes no difference in terms of improving HbA1c. So we showed that in a large trial. I have to say that my colleagues who developed the education program were crying, and they didn't want to publish this. So listen, we've developed this, it's really amazing. Why doesn't it work? Well, actually, it doesn't work. So what about the medical management? So this is looking at primary care in the UK, and we had what we call non-locally enhanced services and locally enhanced services. Locally enhanced services were GPs who were really working hard to control blood pressure here, lipids and sugar, glycemia. And GPs in the UK, they get paid if they get the blood sugars right. And what we noticed, if you look at the blood pressure, about sort of 80% were achieving blood pressure. And in terms of lipids, about 85% were achieving that, but only about 50% of people were achieving good blood sugar control. So even with the best medical management, paying GPs, and GPs who are trained and working really hard with these local enhanced services, they're not achieving the HbA1c, the hemoglobin A1c outcomes that we want. So this results in surplus amputations, kidney disease, and blindness. So even with the best care, if you look at across the world, United States, anywhere in the world, only about 50% of people achieve these outcomes. And that's because of what we do as doctors and how we work with our patients. But there must be a different way of thinking about this. So if you do what you've always done, you'll get what you've always gotten. So if you carry on with the medical approach that's actually education and managing the disease is the way to go, you're going to get the same outcomes. And in fact, outcomes for diabetes have improved somewhat, but they haven't improved remarkably over many decades, despite our medical approach. So let's try to understand it. And the understanding that obesity is a driver of diabetes. And by obesity, I don't mean your body mass index, which is your weight over height squared, but where you deposit your fat. So we'll talk about that. So let's talk about Jennifer, which is a typical patient of mine. Her mother had obesity and developed diabetes in pregnancy, which is high sugars in pregnancy. And when Jennifer was born, she didn't have breastfeeding. Her weight started going up. Her mother was concerned, took her to GPs and dietitians and pediatricians who had no services to help her with this problem. She carried on into adolescence. Her weight started going up even further. She was stigmatized because of her weight. She underwent bullying, developed some depression, and because of excess body fat, she had irregular periods and also was short of breath. Again, her parents were concerned. They took her to GPs, dietitians, pediatricians, and the outcome wasn't what they wanted. And she was having a very poor quality of life. In fact, if you look at the adolescent with obesity, have a health-related quality of life scores compared with children with cancer on active chemotherapy. And not many people realize how bad it is for somebody to have obesity in adolescence. So Jennifer went on. She was very smart. She went to college. Eventually, she ended up having shift work. She had sleep deprivation. She tried to lose weight. She lost weight, gained weight, and eventually she got married. And she put on weight with her marriage. I don't know whether that's a good thing or a bad thing. And her depression got worse, whether because she got married or because of other reasons. Again, she attended GP dietitians and also commercial programs to help her with her weight. But eventually, none of them succeeded, and she wanted to get pregnant. And of course, obesity associated with excess miscarriages, so she needed in vitro fertilization. And she had weight gain in pregnancy and developed gestational diabetes herself, sugar in pregnancy, and hypertension, ended up having a cesarean section, which made it very difficult for her to recover and be able to breastfeed her own child. And in the end, she ended up having more intensification of her treatment. Her diabetes progressed, her depression got worse, she was diagnosed with fatty liver, became immobile, and also developed one of the complications of diabetes, which is uterine cancer. And when she came to see me, she had eye disease, end-stage kidney disease, and needed a renal transplant. But they were saying, actually, your weight is too high to have a renal transplant, and your daughter, who wants to donate this kidney to you, has got too much of high body weight for her to give you the kidney. So she ended up developing ischemic heart disease and had a heart attack. So this is the life of Jennifer. How can we really make a difference in this? Because this is a medical model. We're trying our hardest across the board to stop Jennifer developing all these problems. What we do know is that diabetes is intimately related to weight. So this is body mass index, your weight over height squared, and you can see as you go up the ladder of body mass index here, this is data from the Nurses' Health Study in the US, you will see that the risk of developing diabetes goes high as the body mass index goes up. So there's a really intimate relationship between obesity and diabetes, having too much fat in the body and developing type 2 diabetes. But of course, what we're interested in, there's research going on in terms of quality of life, eye disease, sleep, cognition, depression, smoking, all these factors are related to diabetes, your microbiome, and there's a lot of research going on, but everybody's ignoring the elephant in the room, which is obesity that's driving the underlying problem. And we pay lip service to it. We do talk about diet and we talk about physical activity, but we don't really actually take it seriously medically because we're interested in giving people drugs and medications and medicalizing their condition. So let me tell you about this story that really changed the way I was looking at it. I had a patient who was 43 years old, had severe ascites because she had liver disease, ascites fluid in the abdomen, and also had edema, swelling of the legs, and she had hepatitis B with liver cirrhosis, and she had very bad diabetes. So her HbA1c is 12.8%, and we wanted to be 7% or less, and she had eye disease. That means the blood vessels were affected because of diabetes, and she was being treated intensively with insulin. And we followed her up, and and basically we managed with the insulin to control her blood sugars, and they remained fairly stable. But what happened was her diabetes deteriorated in the end, which shows that when we actually try to treat people the best way we can medically, in the end we fail. We don't succeed in achieving the outcomes that we want for our patients, and her eye disease progressed. But because of her liver, she underwent a liver transplant. She was initially treated with steroids and treatment, and when the steroids were stopped, her hemoglobin A1C was normal, 5%. I stopped her insulin. She didn't have diabetes anymore. So she got a liver transplant, which said to me, in front of me, a patient, that there's something in the liver that's driving this disease, and if we can address this, then we can make a difference in this problem. So this show you, we use this machine, it's called a FibroScan, to look at, it's an ultrasound scan that measures fat in the liver. And if you look at people with early diabetes, what you will see their HbA1c, so this CAP score greater than 341 means there's a lot of liver fat, less than 341 means less liver fat. You can see the HbA1c is 7.3 in high liver fat and 6.6 in the ones who have lower liver fat. And they have high insulin resistance, which are different measures that we use, such as HOMA, and also their insulin levels were higher because of that insulin resistance. They had to produce more insulin to be effective. So high fat in the liver is higher HbA1c, poor diabetes control. So this is the model that we're looking at. So when we have positive energy balance and there's fat in the liver, there's insulin resistance in the liver. And what happens when there's insulin resistance in the liver starts producing sugar because it cannot see any sugar that's outside in the circulation. And because of that reason, the fasting blood sugar goes up in diabetes. Similarly, when there's fat in the pancreas, the beta cells that produce insulin struggle, and they go into dormancy, they go to sleep. And some of them eventually end up dying and not being functional over time. And that's why people end up being on insulin in the long term. So having fat in the liver and the pancreas, you saw it in the patient. The pancreas is not so easily accessible, but I'll show you some data about that. So if we turn off this tap of positive energy balance, can we actually make a difference? Remove the fat from the liver, remove the fat from the pancreas. And it says nothing about body mass index. It's got nothing about how you look. It's all about where you're depositing the fat. We need to forget about the BMI because people with low BMI also have diabetes. They don't have to look different to have type 2 diabetes. So some people preferentially put fat in the liver and the pancreas. And if you can address this issue, can we answer this problem? So this is Jennifer. So Jennifer is worried, how am I going to look after my mother with diabetes? Will I end up like my dad, who had diabetes as well? He ended up having amputations. And she's scared. Her quality of life is low. And the medical establishment says you have type 2 diabetes is a progressive long-term medical condition. You have a disease. You have to manage this disease now. And how we manage this disease is we start you with some tablets. You might develop depression because of your disease and what's going on in your life. You're going to end up having poor vision, increased risk of infections. People with diabetes get worse COVID. You're going to have heart disease. You're going to develop cancer and amputations and potentially kidney failure in the end. So my question was, when I was training, one of my senior colleagues said, you cannot cure type 2 diabetes. And I said, okay, this is a mission for me. I have to make a difference here. And the more patients I saw, the more I thought this might be possible to do something about this. And she ended up on dialysis. So the idea is type 2 diabetes is reversible. Let's have a look at it. Can we do through lifestyle intervention? Why does it have to be medication? Can we get people off medication? Can we make a difference in that? No more medication. Can we really do that? And this was really, I really thought I was crazy, and I am, but that's good. So this is Jennifer being happy without medication. Can we do that? Can we achieve that for her? So we did 2 studies called Diadem 1 and Diadem 2, and basically, I don't know whether you're Harry Potter fans, but this is named after Rowena Ravenclaw's diadem, lost diadem. So we did two studies called Diadem 2 and Diadem 1. And it's a bit like Star Wars film. We did Diadem 2 before we did Diadem 1. So you have to follow that. So Diadem 2 said, can we take people with really advanced diabetes who are being treated with insulin, and can we actually make their life easier by getting them to change their lifestyle and supporting them in a specific way? And Diadem also says, can we put diabetes into remission? Can we stop this disease altogether? So Diadem 2, you can see, so this was a randomized study, and you can see that there are equal numbers of men and women. So in the intervention group, 44.4% men and 55.6% women. But I want to point out the HbA1c here. The mean HbA1c in percent is 8.7 and 9.3. And this is very poorly controlled diabetes. So diabetes, like I said, want to be 7% or less. And these individuals have very high HbA1c. And also they had a long duration of diabetes. You can see there are about 13 years of diabetes, very, very long term. And they've been on insulin for about 4 years. They're all taking insulin to control the diabetes. So we put them on a lifestyle intervention. It's very similar to Diadem 1, because I'm going to delve into Diadem 1 more, so I'll explain what we did later. But what we noticed was you can get them to lose weight. And this was a 6-month intervention. There was some weight regain afterwards because we didn't have as close a follow-up, and we had to learn from that. So we managed through a lifestyle intervention that I'm going to describe to you to get them to lose weight. We managed to improve their HbA1c. So the HbA1c, remember, it was 9. Now we managed to get it down to 7. The control group got a good deal because they were in a research study and the doctors were working really hard. And I said, we must show that the medical treatment works really well. So they're really working hard. So they managed to improve their blood sugars, but not as well as we did in the lifestyle intervention. You can see the insulin dosages of the ones, because in the black is the intervention group, the insulin doses came down. And 39.4% of the intervention group stopped their insulin altogether. No more injections, no more injecting yourself 4 times a day with insulin. So, and their quality of life improved. So quality of improvement in the intervention group by 11 points compared to 0.71 points in the control group. So we can take really advanced diabetes, people who are treated with insulin, who, in a way, the medical establishment said, I cannot control you, so you have to have insulin. We can get them off insulin, their quality of life improves. We can do that. But can we go a little bit earlier? Can we do Diadem 1 and take people earlier before they get treated to insulin and actually make a difference there? So that was Diadem 1. So Diadem 1 was set up in Qatar. So Diadem 2 was done in London with my student Adrian Brown. So Diadem 1 was done in Qatar. So the setting is Qatar, where there's a high prevalence of obesity. About 40% of adults have obesity and 20% of adults have got diabetes. And it's a multicultural, multi-ethnic society. So we decided to do this study in Qatar because of the branch campus of Cornell, and I was a faculty there. And everybody said this is impossible to do a clinical trial in Qatar, that they don't have any infrastructure. So we built that infrastructure to be able to do that clinical trial. So the first thing we do when we do a clinical trial is look at what's out there. Have people actually done anything before? So we looked at all the randomized controlled trials in the region, looking at bringing weight down. And what we found, actually, there was hardly anything. Nobody had done anything, and nobody had even thought about reversing diabetes or changing diabetes or any of that. So we decided to do the first trial in Qatar, the first trial in the Middle East and North Africa region, to be able to address this question. And we had to learn how to do it. What kind of intervention are we going to do? So we had to learn from bariatric surgery. So we know that people who undergo bariatric surgery, this is called the Swedish obese study, have been followed up. If you follow them up to 15 years, in darker blue, you will see that the ones who have bariatric surgery go into diabetes remission. So getting weight loss through bariatric surgery has a significant effect on getting people into diabetes remission. But what is special about bariatric surgery? What can we learn from that? What's happening in bariatric surgery that we can then translate into other interventions? So what did we learn? Weight loss is a key component of diabetes improvement, but weight loss is not about how you look. And weight loss translates into reducing liver and pancreatic fat. Weight loss has to be rapid, and mainly in the first 3 to 6 months, which occurs in surgery. And we know that people who manage to bring their weight down early are the ones who succeed in the long term. The old idea that you have to lose 1 or 2 pounds here and there is not valid anymore. So we believe in rapid weight loss are the people who are going to succeed in the long term. And the other factors are related to remission, where if people were younger, when they had diabetes, if they had bariatric surgery, they're going to go into remission. If they had early disease, if their sugar was better controlled, they were on fewer medications and not taking insulin. So these were the individuals. But of course, bariatric surgery is only provided to less than 1% of people who need it across the world, believe it or not, even though there's so much hype about it in the news. And most of the people who are being treated are the ones who have very advanced disease, not the ones who are younger with early disease. We also had to learn from 2 big studies carried out in the US called the Diabetes Prevention Program and the Look Ahead study. The Diabetes Prevention Program was to preventing diabetes from pre-diabetes to diabetes, and Look Ahead basically wanted to do a lifestyle intervention in people with diabetes, established diabetes, see what happens. And what they showed that those people who attended the appointment did really well in terms of weight loss. Those who restricted their energy intake, also the ones who used meal replacements, and we got the idea that actually meal replacements could be really important. And I'll tell you why in a minute. Increased physical activity was important, early weight loss. So the Look Ahead study, the greatest determinant of weight loss in 4 years was weight loss in year 1. So 10.4 times more likely to maintain 10% weight loss if they achieve it in the first year. So this is what we learned from Look Ahead. So can we put it all together? Bariatric surgery, diabetes prevention program, Look Ahead, and Diadem 2. So we put this all together, and we decided to recruit younger individuals because we knew younger people are likely to develop diabetes, worse diabetes, and we might be able to intervene better. And the interesting thing about Qatar is that actually people develop diabetes about a decade younger than in the US. And this is really important. So we needed younger people, we needed people with early type 2 diabetes, with an intensive lifestyle intervention compared to best medical care, with a new philosophy, early weight loss, introduce physical activity, and we wanted to do primary care and the community, because that's where the problem is. The problem is not in your hospitals with the gadgets and MRI scans, the problem is in the community. It's a big population. So this is what the program looks like. So it goes into 12-week blocks, phase 1, phase 2, phase 3, phase 4. So we do what's called a TDR, which is total diet replacement. And this is giving people shakes and soups and bars and things like that. I said, this sounds really horrendous, but actually, is it easier to take multiple medications and injections? But the idea is to actually reset your metabolism, and that's what part of the diadem is, and give you a chance to then re-educate them throughout, but then in phase 2, doing partial meal replacement, introducing food and healthy food, and getting them to become active. And after that, they'll be on their own food and they'll follow it up. So they saw a PE physician, a dietitian, and a trainer. So the physician works in terms of the medication. So from the get-go, the people in the intervention arm were told, look, you don't have diabetes anymore. We're going to stop all your medication. They were horrified. So I had a dustbin next to my desk, and they brought their medicines, and that's what I did a lot of the time. So we stopped all their medications for diabetes. Is that scary? So we're going to stop everything. And the dietitian then works with them in terms of how to deal with the meal replacements, how to re-educate themselves in terms of using meals, and the trainer to introduce physical activity. And we defined remission as an HbA1c also 6.5% off medication after 3 months. And this has now become the gold standard for the world. And we set the standard in terms of what should we call diabetes remission. This is published in the Lancet Diabetes and Endocrinology. And it's got many of our colleagues involved. One of our colleagues, Professor Martin Wells, was the chief statistician for the study and is here, thankfully, tonight. So you can see in terms of what happened to diet, so the red is the intervention arm. The control is the normal medical care, but it was actually normal because we were again working really hard to give them the medication that stops obesity and really help them with diabetes. And what we showed that the ones in the red, they lost weight in the first 3 months, and they maintained it up to 12 months, which was the follow-up period. So they lost about 12% body weight over time that they maintained at 12 months. And this was mainly fat. So their body fat, or total body fat, was reduced, as you can see in the red. It's got much lower body fat compared to the control group. And I can tell you they lost no muscle. There was no muscle loss in any of this, and that's because of the way we did it, including physical activity. I can tell you there was no difference between whether you're a man or a woman in terms of response. So there was no difference in terms of response based on sex, and there was no difference whether they came from the Middle East or North Africa. And this was a crazy study in Qatar, because most of the studies that we do are not generalizable. So if you do a study in the US, it may not be generalizable to the whole population, whereas in Qatar we had people come from 13 different countries with 13 different kind of backgrounds who needed to go through this program. And what we observed, and this was remarkable, you can see 60% of the intervention group achieved 5% weight loss, 34% achieved 10% weight loss, and about 1 in 5 achieved more than 15% or more weight loss. Now, if I were selling a drug to you that achieves that weight loss, you'd be buying it. You'd be searching the internet for it. We managed to actually really demonstrate that we can achieve really good weight loss that is maintained up to 12 months. And their HbA1c improved. You can see the blue, the control group, of course they improved because we were giving them more and more medication to control their HbA1c. But you can see 7 is the standard. And we've taken these individuals with early diabetes, and we're achieving really good blood sugar control that's sustained up to 12 months. And the headline is 61% of these individuals went into diabetes remission, and 33%, 1 in 3 of the individuals in the intervention, had no sugar problem at all at the end of 12 months. The sugar wasn't even the pre-diabetes range, so they had absolutely no problem with diabetes. There was some remission in the control group because they were talking about it. They changed their lifestyle by being in the research study. But actually, you can see it's really remarkable that actually this intervention, 1 in 3 individuals can have normal blood sugars. What we did do in this study is we used what's called continuous glucose monitoring. It's a monitor that you wear that measures your blood sugars across the day, across many days. So when you look at the blood sugars here in the baseline, you can see the green area is where your sugar should be. So in this control group individual, you can see the sugars are going up and down outside the green range, and it's very variable. It's like riding a roller coaster. And the same was true in the intervention group. But what happened at 3 months, so each different day is a different color, by the way. So at 3 months, you can see the control group, despite giving the medication, the sugars are still out of control, and it's out of the normal range, out of the green range. But what happened to the intervention group? And then when you follow up for 12 months, still the control group, despite the best medications, had this huge variability in their sugars, and the intervention group, the sugar is normal. Shocking. I called my colleague and I said, you remember you told me we can't do these things? And I said, here it is. And what we showed was in the intervention group, the liver fat, we used the FibroScan to measure the liver fat, and you can see the liver fat went down. So it fitted with the story of my patient, it fitted with what we were thinking, that actually liver fat was a really important aspect of what was happening. And we know that people going to remission, this had the largest lowering of the liver fat. So it's not about how you look, it's not about your body mass index, it's all about where you're depositing this fat. And we showed that the ones who went to remission achieved greater body fat, with greater liver fat loss compared to the ones who didn't go into remission. Of course, when you do a trial, you want to know whether any adverse events, does anything bad happen to people when they go out and undergo this intervention? You can see nothing bad happened to the individuals underwent the intervention. In fact, it was the control group who had much more complications going on because of their diabetes. And this was remarkable as well. 71% of the people on the intervention did not need blood pressure medication, and their blood pressure was normal by the end of it. So it wasn't just looking at that. I can tell you that actually their lipid profile, their cholesterol profile improved as well. So the bottom line is we managed to make them non-diabetic into remission. We helped their blood pressure and we helped their lipids. How much can I charge you for that drug? Now we know that having diabetes and obesity is an inflammatory state. So measure this thing called C-reactive protein that's produced by the liver, and it shows how much inflammation is going on. And you can see with the intervention of 12 months, the CRP levels went down. And the white cell count, even though they didn't have infections, white cell count is a measure of infection, you can see that even with diabetes and excess body fat, the white cell counts are high, as if you have infection. And this was lowered at 12 months. Similarly, we measured this thing called PI1, and the reason I highlight this is this plasminogen activator inhibitor in the blood is produced by adipose tissue, the blood vessels, endothelium, platelets in the circulation, and also immune cells, and it's related to hypertension, cardiovascular disease, obesity, insulin resistance. And also, we know the people who have had PI1 levels that were high are the ones who had the greatest worst COVID outcomes. So what happened to PI1 in the individuals with this study? You can see with the intervention, the PI1 levels went down. So all measures of inflammation were reduced. So the body was no longer on fire, it wasn't crying anymore, and it was off medication. And what about mental health? So you can see in the ones who underwent remission, I can tell you that these individuals, because they had early diabetes, they didn't have very high anxiety and depression. Whereas you look at people who are at advanced diabetes, they have much higher levels of depression and diabetes. But even in these individuals, the ones who had the intervention and went into remission ended up reducing their anxiety and reducing their depression scores. They were happier. They were bouncing into my office rather than the patients who come into my office saying, I know what you're going to say, my HbA1c is out of control, and you're going to give me more medication, my life is not good. So this is a study that was carried out in the UK simultaneously, and this was done in the UK, like so people a decade older, and in the UK they showed that 46% remission, which is lower than ours, and that's because they were older. So you have to realize that the younger we catch the disease, the earlier we catch the disease, the more likely you're going to get an outcome. So you get lower outcomes with the same kind of intervention in a generally white population in the UK. So with this group in the UK, what they did is look at an MRI scan with the same intervention. So if there's no diabetes, so that's the green box there, you can see the pancreas looks really happy and voluptuous and happy. Whereas if you look at somebody with diabetes, you can see the moth-eaten appearance of the pancreas. And when they undergo the intervention, you can see the recovery of the pancreas. Isn't that amazing? Objectively, on an MRI scan, you can see the pancreas wake up and rebuild itself. So it's possible to do that. So we may think of it differently now. Let's think about the disease differently now. And this is now a study in Australia now. So in Australia, they use a slightly different intervention, but they showed that the ones who achieved more than 15% weight loss, 87% achieved remission. So the greater the weight loss, then is you have to lose some weight to get that fat out of the liver. And if you get that fat out of the liver, then the outcome's going to be, and the pancreas, the outcome's going to be good. So this is looking at in terms of weight loss in different studies. You can see diadems at the top, the greatest weight loss observed in all the different studies that have followed since, that the greater the weight loss, the greater the chance of remission. The more we can get to that liver fat, the better the outcome. And this is because how fat operates. So when you deposit fat, initially the fat is deposited in subcutaneous tissue, and you have a limited resource there. And when that resource is exhausted, it starts depositing the fat in the liver and the pancreas and the heart and the kidneys. So when people lose weight, you will see that they change in appearance, but you need to get to that fat in the liver. And that's what our target is, not what they look like. So we teamed up with the DIRECT study. So just to point us to type 2 diabetes reversal, in the DIADEM study, the threshold 78% in those who completed the program. So if you complete the program, for the ones who go into the program, it's 61%. For the ones who actually stay right to the end, 78% achieve remission. And you can also see that with the DIRECT study, there were mainly a white population, whereas we had people from the Middle East and North Africa, and they had a slightly longer diabetes duration, and that's why they got lower outcomes in the UK in terms of diabetes remission. So they were older and had a slightly longer diabetes duration. And what we did was we measured proteins in the blood. Because it's really hard to follow people up to see whether they develop cardiovascular disease or not. So we've developed proteomic panels have been developed, protein panels in the blood that you can measure, several proteins together, that can predict somebody having a disease, like cardiovascular disease and other complications. So we teamed up with the DIRECT team, and what we observed, that based on the protein levels in the blood, the cardiovascular risk was reduced. They were fitter, the cardiorespiratory fitness was better. The visceral fat in the viscera, in the organs, was reduced. Liver fat was reduced, and body fat percentage was reduced. So in the DIADEM study, based on protein levels, there was a 20% reduction in cardiovascular risk by undergoing through this program. Now, the look-ahead study, which I alluded to, they put people over 5,000 people into intensive lifestyle intervention or diabetes structured education, and about 12% of these individuals achieved diabetes remission altogether, and about 7% remained in remission at 4 years, and they were followed up to 12 years. And what they observed was, as you can see, the prevalence of remission is early on is high, but it does go down over time. But again, the intensive lifestyle intervention, which was different from what we did, achieved a higher level of remission compared to the diabetes structured education. But the headline for them was, although the mean weight loss wasn't great, it was about 4 kilos and 2.2 kilos at 1 and 4 years. When you follow them up, what you observed, there's a 40% lower risk of cardiovascular disease and 33% lower rate of chronic kidney disease. These are actual hard outcomes. So if somebody has type 2 diabetes and goes into remission, we've shown with proteomics that it reduces your risk. They actually looked at actual events. How many people go into chronic kidney disease? How many people have heart attacks? How many people have strokes? And this was reduced because they had the large numbers to follow that up. You can see that the ones in the intensive lifestyle group achieved remission, and at least 4 visits, they kept it going, 60% lower risk of chronic kidney disease and 35% lower rate of cardiovascular disease. So they matched what we were finding in the proteomic panels. Actually, going into diabetes remission achieved longer outcomes, even if you don't maintain it, because it's something called metabolic memory. And we don't really understand what happens is having that period of the blessing of remission has long-term outcomes. And this has been shown up to 10, 12 years, that if you go to remission, even if you could develop diabetes later on, and some may do, and regain some weight, they will have less complications, less cardiovascular disease, less chronic kidney disease. And here it shows it very nicely. You can see the ones who had more than 4 visits had lower CKD, and there was remission more than 4 visits, and the ones who had remission more than 4 visits reduced cardiovascular disease. This is amazing. So we looked at what are the factors that are related to people making changes in diabetes. So we talked to our participants. One thing they said, what triggered them into making this lifestyle change was the right timing. They had to be ready for it. It has to come at the right time for them. And they felt that the intervention has to be early in the disease where it's not fully established. They expressed that they had to be ready for change, and they also had concerns about their future health. So if you had all those, that triggered them into wanting to change their lifestyle, and what motivated them was to go into diabetes remission. Once I told them, our aim is to actually get rid of your diabetes for as long as we can, then that became a really big motivator. And they observed their weight loss, and the medication going was a real blessing for them. No more side effects, no more having to buy pills, no more having to come to the doctor just to be given more prescription or be told off that you're not doing what you're supposed to be doing. And the facilitators we taught them about the disease, what we were thinking about it, what the drivers are. We allowed them to have self-sufficiency to keep them going. They had to be in charge of it. And we supported them. So remember, earlier I said the people who attend their appointment more, the more support you give, the better the outcome. So the more you vacuum your house, the cleaner it's going to be. But most people clean their house and they throw away the vacuum cleaner. That's not what we do. And the barriers that they identified was basically the previous behaviors, being the kinds of foods that they were eating. They had to make those changes. The sociocultural environment was very difficult, going to parties and buffets and traveling, and people saying, "Oh, you look really well. You don't really look well. Have you lost weight?" So there's lots of sabotage that's going on, and so the sociocultural environment was important. But obtaining positive results was one of the factors that overcame these barriers. So don't just believe me. Let's listen to one of the people who participated, and this was covered in the BBC World Service.
I can't forget when I go in a clothes shop to ask about anything, they told me, sorry, we haven't used that. So the very difficult sentence to hear. Yes, I am still young, and it's very interesting.
I used to be 138 kilos, and now I am 180.
He went to 80 kilos, by the way. He went to 80 kilos.
I can walk, I can run, I can ride bicycles, and I'm feeling good, feeling better. Yes, difficult journey, but it's the best journey I make it in my life.
So, to conclude, diabetes remission is a reality. Welcome to the new world. We need to rethink about type 2 diabetes as a chronic disease. We need to achieve type 2 diabetes early. So I've written an editorial here. It's the new mission in diabetes care. That's what we need to do. And based on our studies, we need to translate now this into practice. So there are diabetes reversal clinics appearing within the healthcare service. There are now companies who are interested in developing diabetes reversal, using different approaches. Perhaps it has to be centered in primary care, where most of the disease is. It has to be linked to a screening program. So Qatar has a national screening program. So as soon as somebody is diagnosed, then we can put them into a program to be able to put them into remission. And of course, we've changed the standards of care. We've changed the world guidelines based on our studies. So the American guidelines now talk about diabetes remission as an outcome. The European Society of Cardiology is also recommending it. So many of the guidelines have changed now. So one of the things that they emphasize is a person-centered care based on thinking about providing an element of diabetes remission. So no more lip service to lifestyle intervention, eat less, more. We need actual really directed, well-designed programs to be able to put people into diabetes remission. It's really gratifying to go to Qatar where there's a big problem, set up clinical research from the get-go, do the first clinical trial in Qatar and in the Middle East and North Africa to look at this and to change guidelines. And hopefully this will make an impact into people's lives now. So we need to, there are also research needs. So timely interventions are really important. So we need to look at how early we can get them. And now we're talking about pre-diabetes, putting them into the same program to be able to achieve the same outcomes, linking it well to screening. There are other dietary approaches that can be used. Ours was only one approach. We didn't supervise physical activity. We only advised people about physical activity. But what if we actually supervised them? We actually was there and telling them what to do exactly and did the exercise with them? Can they achieve better outcomes? Of course, we need to think about how long can we maintain this. I mean, weight loss might be easy for some, but maintenance of weight loss is the greatest challenge. But even so, being in remission, like I said, buys you time. And that time is really valuable in terms of metabolic memory. Can it be done remotely? We learned from COVID that many clinics and appointments can be done remotely with new technology. Can we combine it with medication? We now have weight loss drugs, and in terms of maintenance, that's can the two come together? Although my philosophy is not to poison people as much as I can. And also, can we do the same intervention with other obesity complications apart from diabetes? How many obesity complications do you think we have? Give me a number. 6? Okay, there are over 204 complications of obesity established. So I showed you inflammation, we reduce blood pressure, we reduce cholesterol, we reduce diabetes. And we now know that weight loss reduces cancer, reduces cognitive decline. So there are all these complications of obesity, which unfortunately is a clash of the environment and genetics. But we can make a difference in this, and maybe the same interventions can be applied to other obesity complications. So this was funded by the Qatar National Research Fund. My research in Birmingham was supported by National Institute of Health Research in the UK, and of course also support from Weill Cornell Medicine. And many colleagues have contributed to this. It's not, although you have me speaking with you about this topic, many people have contributed to my research over the years, particularly this one who worked very hard and lost too much weight. But actually, lots of people, you can see Martin Wells, who's here, Mary Charlson next to him, many people in Qatar who've contributed to my work, many people in Imperial College, it's Adrian Brown. Well, I can show you Adrian Brown, who's my PhD student here at Imperial College. So many people have contributed to this study. It's not a one-man show. So many people have worked hard to give you the answer and to change the guidelines to give people the hope that they can actually put type 2 diabetes into remission. Thank you for listening.